Good afternoon, everybody. My name is Garrett Schmidt, and I am the managing editor for ACO Exhibit Hall. And I'd like to welcome you all to today's webinar hosted by Salient Healthcare called Preparing for Risk, the Intersection of Compensation Design and Performance Improvement. A few items of note before we get started. Everyone has joined today in listen-only mode, so you don't need to worry about muting your mic or that has already been done for you. And I'd like to let you know, too, that the webinar is being recorded. So you will have the opportunity to rewatch the session and share it with colleagues after the fact. And we want you to do so. So feel free. And what I'll be doing is sending out a link after the presentation to everybody, probably this evening, that will have a link to the recording and to the slide deck that you can download. That will be there for you. During the webinar, we want to hear from you. So please submit your questions. You'll have a little module, like a little attendee module that'll have a question section on it. So you can submit your questions there. And at any time, you don't have to wait till the Q&A time, but we'll actually address those questions at that time, and our speakers will do so. If we're not able to get to your question today, don't worry. We'll get back to you via email afterwards. But again, we do want to hear from you, so please let us know. Okay, so our presenters today are Ms. Maria Nikol, who's a senior business consultant with Salient, and also Mr. Mike Gizzi, who is a senior consultant with Sullivan Cotter. So we're super excited to hear from them today. And so at this time, I think Mike is going to get us started. So welcome, Mike.
Thanks, Garrett. Hello, everyone, and welcome to the Sullivan Cotter and Salient Healthcare webinar about preparing for risk and value-based care. Today, we will spend about 40 to 45 minutes talking about the intersection of compensation design and performance improvement, performance management, as they relate to value-based care strategy, value-based care operations, and driving strong VBC program performance. We will have about 15 or 20 minutes at the end of this material for questions and discussion. Maria and I are both really excited to share some insight with all of you today and share some information also about Sullivan Cotter and Salient Healthcare and how we may be able to support your organization in the future. As Garrett mentioned, my name is Mike Gizzi, and I am a senior consultant at Sullivan Cotter, and I lead our value-based care solutions team. Sullivan Cotter is a firm of about 250 professionals with offices all across the country and has been in the healthcare space for almost 30 years. Sullivan Cotter specializes in delivering tailored advice, research, and tools across the full spectrum of today's healthcare workforce to uncover and accelerate drivers of performance. Sullivan Cotter services 4 primary workforces: physician workforce, executive workforce, advanced practice provider workforce, and the employer workforce. Sullivan Cotter has unique experience and capabilities to accelerate and align reward strategies, specifically in and around compensation philosophy and strategy development, plan design, effectiveness review, benchmarking, surveys, and research, and administration. Lastly, Sullivan Cotter has been expanding and developing new services the last 3 or 4 years around physician affiliation strategies, value-based care performance, and provider needs assessments. These areas relate and overlap and influence compensation more than ever in today's healthcare environment. Maria, can you take a minute or two to tell us about yourself and Salient Healthcare?
Yeah, thanks, Mike. And hi, everybody. This is Maria Nikol, and I am a senior business consultant at Salient Healthcare. I've been in the healthcare industry for over 11 years, focusing specifically on program and process development of value-based organizations in various roles, including supporting and working with accountable care organizations, practices, and payers. Salient has been in the performance management space for over 30 years, and over 15 years ago, Salient ventured into the healthcare space with our first client, New York State Medicaid. Since then, we've been helping organizations take on risk in their value-based contracts by identifying performance across key performance indicators. I'll go ahead and hand it back to Mike.
Thanks, Maria. Today we have a great agenda that will guide the discussion and hopefully some great questions at the end. Please feel free to submit questions or comments, as Garrett mentioned, in the chat area, and we will do our best to answer those at the end of our presentation. I will start with some background and industry oversight. I really like to start the value-based care discussions with this slide because although we are focusing on compensation design and performance management, you can see the use of many great buzzwords in the VBC world today on this slide in particular. Optimizing clinical care, enhancing performance, and ensuring financial stability are really the overarching goals of most, if not all, value-based care strategies. I certainly don't want to leave out the ultimate goal here, which is the patient or consumer benefit. Healthcare in the last 10 years, especially today and over the last 12 months with the global pandemic, has witnessed unprecedented changes, uncertainty, and the potential for disruption. These conditions are having a material impact on health system performance all across the country. What are the solutions? Value-based care reimbursement models and population health management. The goals here are actually quite simple from a conceptual standpoint. Improve cost and quality outcomes, foster accountability for physicians, advanced practice providers, and patients, and improve coordination of care and clinical innovations. As you can see at the bottom of this slide, commercial payers have announced large-scale growth plans for value-based contracting programs going forward. We at Sullivan Cotter and at Salient Healthcare don't see this trend or momentum lessening anytime in the future. These environmental factors, along with the cost pressures and reimbursement concerns, will have a significant impact on the future of health systems organization structure, value-based care initiatives, and the needs of each workforce. As Sullivan Cotter works with clients all across the country, we are seeing this trend intensify as we support health systems with compensation design efforts and other strategic initiatives. Sullivan Cotter has developed a strategic framework that identifies key market pressures accelerated by the COVID-19 pandemic for healthcare providers throughout the United States, including the implications and needs for enhanced workforce optimization to address some of these changes. At the top of this slide, we note that along with other market pressures, the increased financial and healthcare delivery challenges from COVID-19 have also accelerated our clients' need to focus on the following: clinical innovation, technology disruption and opportunity, regulatory shifts, capital access deployment, and consumer preferences and actions. As you can see outlined in the middle of the slide, most of our clients have also identified at least 2 additional critical success factors, which have been accelerated by the COVID crisis as well. Whether highly distressed and impacted or relatively stable, our clients across the country have accelerated their emphasis on the cost of care and enhancing efficiency, identifying more areas for revenue growth and diversification. It is here where you could start to see very clearly how this relates to compensation design and performance management within VBC models to ensure and drive optimal success. Lastly, as outlined on the bottom of the slide, we have also observed a wide range of strategic responses to advance the critical success factors above. These include initiatives focused upon improving and revising their scale and scope and overall capabilities, technological innovation, partnerships, employee well-being and safety, care delivery transformation, and performance alignment. We're now going to dive a little deeper into compensation design and planning. Before we talk specifically about compensation design as it relates to value-based care and incentive alignment, operations and performance management, we need to know where a health system, hospital, or physician group currently sits on their VBC risk continuum. I am often surprised that many healthcare leaders across the country don't even know exactly where they are on this continuum in terms of risk tolerance and preparedness. Before an organization can start to tailor and develop a VBC or population health management strategy and eventually address compensation design or performance management, it is critical to know what strengths and weaknesses exist and how fast your organization would like to progress towards more risk or possibly a next generation ACO or maybe even a commercial full risk arrangement with a commercial payer. Both teams at Sullivan, Cotter, and Salient Healthcare believe understanding this current state is a critical first step. As healthcare continues to evolve and strategic imperatives do shift, there is a greater sense of urgency around long-standing issues. One of the more significant impacts from COVID-19 from a compensation design standpoint was around sustainability. The COVID pandemic has highlighted and emphasized key challenges to ensure the right workforce composition, deployment, and supportive compensation arrangements. There continues to be significant and real pressure to have an affordable and aligned, as well as incentivized workforce, and the compensation arrangements must include both minimum accountability and incentives that motivate the needed behaviors to accomplish value-based care goals. Increasingly, the alignment of healthcare provider rewards programs is critical to ensure a complementary environment versus a competitive, team-based care delivery model. Very often today, organizations are addressing physician and APP compensation design together in a holistic way. It is very important, however, to understand the starting point of key compensation design elements between each separate group. For example, physician compensation is universally driven by the physician's specialty area, while the compensation for advanced practice providers is largely driven by their role within the care delivery model. Are they independent practitioner? Are they part of a team-based care delivery model? How sophisticated is that model? Do they play a support role? The answers to these specific questions will help guide how their compensation should be designed to integrate with the physician compensation model. Other key questions include, what is the practice environment for the physician? For example, do the physicians primarily work shifts to support the patient volume in the hospital? Or are they in a primary care setting managing a patient population with a focus on care coordination? Lastly, it is also important when reviewing advanced practice provider compensation that you compile an inventory of historical pay practices, which are typically very different than physician pay practices. You can see many of the design elements exist for both physicians and APPs. As it pertains to value-based care and operational performance improvement, health systems need to decide what type of care delivery model they are trying to build or enhance, and how compensation design can support those initiatives and strategies. Primary care compensation design example. Sullivan Cotter recommends a flexible compensation program that can adapt to future changes in reimbursement. Consider the right weighting of panel size with respect to the primary care reimbursement environment and definition of a panel size. One important element here to remember as you view this slide is there are stages and steps to move to a more population health or value-based care oriented type of model. Sullivan Cotter leverages our national compensation survey and design experience all over the country to tailor different models for different clients in different geographies, depending on where they are on the VBC risk spectrum. CMS's recent primary care first payment model is a great example of changing reimbursement for primary care. Our team at Sullivan Cotter would be happy to discuss these models and others in more detail if anyone has questions in our audience today or would be interested in more information. One question we are often asked is how physician pay differs by region. On average, median staff physician TCC, or total cash compensation, varies plus or minus 9% from the national median, depending on the region. However, as you see here, each region is defined as multiple states, which include a variety of local markets and geographies. While there are regional differences, we find that there are less significant than other healthcare workforces. For example, nursing, due to the national recruitment of physicians. The Northeast region has historically lagged behind the national median, which may be indicative of supply and demand. The Northeast region, as represented by this illustration here, has the highest number of teaching hospitals. Many residents and fellows prefer to remain in the same geography where they completed their training. That means organizations in that region have a greater supply of physicians to recruit from. The Northeast region also has a larger number of urban locations. Organizations in more rural areas, such as the West, South, and Southwest, where teaching hospitals are limited, often have to offer richer compensation plans and designs and benefit programs to attract new physicians to relocate to those areas. This slide was created from Sullivan Cotter's national survey data, and we believe it highlights the variance across the country and in different regions. When it comes to the intersection of compensation design for all specialties and performance management, Sullivan Cotter has seen that these are the best questions for consideration. The large concepts or areas of compensation design are best defined by the answers to the questions on the right. What are the agreed upon performance drivers? How should each component be weighted in the new compensation program? How should each performance metric be measured and rewarded? Individual, team, practice site, region. What metrics require physician and APP collaboration? Is there team collaboration? Sullivan Cotter has used this illustration for several years on the prevalence of, oh, I'm sorry, Maria, next slide, please. That was my mistake. Sullivan Cotter has used this graph for a number of years now on the prevalence of measures considered in incentive and discretionary pay. This was also developed by Sullivan Cotter's National Compensation Survey process. Consistent with prior year results, the top 4 measures have been the highest utilized measures, with patient experience leading the top with 73% utilizing this metric. 2 metrics that saw increases were the HEDIS measures, which increased from 15% in 2019 to 23% in 2020, and citizenship metrics, which increased from 21% to 40% in the same time period. Citizenship metrics have been an area that we've seen variability in from year to year. And just to make sure we're all on the same page, when we talk about citizenship, we are speaking about things such as meeting patient-facing hour expectations, completing charts in a certain time frame, attending departmental meetings and care team meetings, etc. Given the challenges around identifying and defining these metrics for certain procedural-based specialties or pediatrics specialties, for example, some organizations have incorporated citizenship metrics in place of value-based care measures that are less mature, and there is less market data to compare against. Rewarding population health management with panel management. Panel management is one of the buzz terms that seems to be on everyone's discussion list of late. The majority of organizations risk adjust the panel to recognize the effort of managing different population segments in their geographies. The outcome of this compensation structure, combined with significant communication, scorecards, and other organizational leadership, was an increase in patient access through physician and APPs working together. Here we define panel size as the number of patients seen by a physician, typically within the last 18 months. Here, panel size was acuity adjusted by age and gender to reflect complexity of care. On the left portion of the slide is a scatter plot with panel size on the x-axis and work RVUs on the y-axis. Targeting the right combination of both RVUs and panel size, we found that it served as a proxy for many of the traditional access measures, such as third day or third next available appointment, lag time, or new patients seen. The important takeaway from this slide here is that panel methodology and panel concepts around compensation design are becoming more widely implemented and leveraged across the country. How does a health system effectively manage risk? A few minutes ago, I mentioned puzzle pieces and the many moving parts to value-based care programs and design strategies. And this is really one of the best examples that Sullivan Cotter can provide to illustrate the complexities and many moving parts around managing risk in value-based care environments. There are so many critical moving pieces to developing a successful VBC program and driving positive performance in a population health management model. Sullivan Cotter has defined on this slide 4 key areas: business model alignment, enhanced care delivery, consumer and provider engagement, and operational excellence that summarize most, if not all, of the moving parts I referenced earlier. The examples below the 4 buckets on this slide are basically the nuts and bolts of a value-based care population health management program. I want to highlight one example on the far right under operational excellence. You will see listed towards the bottom there, compliance and audit. The annual wellness visit is a key strategy for successful value-based care models. These procedures require specific attention to billing, coding, scheduling, and documentation. Is your health system or organization executing this strategy correctly? It's often a question that is difficult for health system leaders to answer accurately and in a timely fashion. Maria is now going to share some detail about Salient's cloud-based performance management solution. You will soon see that this solution overlaps significantly in each one of these 4 key areas. Maria?
All right, thank you, Mike. So there are 5 main categories that have to be satisfied for value-based organizations to finish with a spend that's below their benchmark, exceed the minimum savings rate, and hopefully achieve shared savings. Those categories are finance, risk, attribution, quality, and utilization. For finance, one of the key metrics to track is the spend PMPY versus the benchmark. It will tell you whether you're on track for shared savings. With regard to risk, it's always important to keep an eye on your population's risk score, both at the organizational level and at the practice and provider level. Appropriate coding leads to a more accurate benchmark, and that enables you to anticipate the actual cost of care and the type of care that your patient population requires. This is the only way that payers know how sick your patients are and gives you credit for all the hard work that you're doing. Now we move to attribution. We recommend that you look at 2 attribution metrics: the percent continuously attributed and the percent of beneficiaries seen per quarter for primary care services. Based on our experience, those beneficiaries that have continuous assignment typically have a much lower spend. And this is likely because they're getting the right care at the right time. Working our way over to quality, we recommend that value-based organizations monitor their annual wellness visit completion rate, as Mike had just mentioned. This KPI literally impacts all of the other 5 categories. Your organization ultimately benefits as every single quality metric improves. Annual wellness visits reimburse at a higher rate than your standard E&M visit, and they help to develop a better patient-physician relationship. So this brings us to the utilization category. First, we look at the TCM percent completion, since completing TCMs can have a significant impact on unnecessary readmissions. We also look at the visits per 1,000 for acute and post-acute care and the 30, 90, and 180-day readmission rates. Now, depending on your contract, it may be helpful to implement initiatives around network management or working with your assignable populations. In network management, organizations may want to work on creating preferred provider networks by identifying specialists that are high value. Your organization will want to track whether those patients are truly seeing preferred providers or whether they're going out of network. If your organization is engaged in multiple value-based contracts, then Salient is actually able to show you your in and out of network provider designation that is payer specific. Many value-based organizations will also receive the assignable patients, not just those that are attributed. The assignable population may be helpful in growing your attribution and the size of your organization. Salient has developed proprietary logic that helps you identify how likely that beneficiary is to become attributed to you. All right, so now I want to go ahead and switch over my screen to take a look at the Salient Healthcare dashboards. You'll find that the information in this demo set is completely devoid of any PHI, so I'm not going to be revealing any PHI during this demo. It did log me out for compliance and security. And on the first page, you're going to see the first page that our clients see when they log into the dashboards. This is our landing page, and you can see on the widgets above that this is the MSSP data along with the Humana and the United Healthcare Medicare Advantage data. Now, you can see that these two contracts are here just for the sake of an example. We also have the capability to bring in any other payer data, whether it be MA, commercial, Medicaid, or Medicare Advantage. It's important to note that Salient organizes and analyzes the data for continual performance improvement. Along the top, you'll see that the same categories that I'd mentioned earlier appear: finance, risk, quality, attribution, and utilization. Also, on the landing page, you'll see that the categories manifest in your benchmark, your spend to ensure that you're under the benchmark. You'll also see the unique attributed beneficiaries, the HCC scores, and the annual wellness visits, which we use as a proxy for quality. Now, how nice would it be to show your annual wellness visit completion rate across multiple populations, all in a single platform? Salient also has actionable lists on the other dashboards that I'll show you a little bit later that allow you to get your data to those that need it and when they need it. Now, you'll also see red and green highlights throughout. And these are directive and designed to tell you if you're trending in a desired or an undesired direction. In this case, there's no yellow highlights, but if there were, that would represent little or no change. You'll also have some MA trends that are available to show you the net revenue over time. Now I'm going to go ahead and use the aforementioned navigation bars to take us into our ACO scorecard located under the financial category. Now here you're going to see the 8 widgets, all that represent the KPIs as percent changes so that you could see how your organization is trending between 2 time frames. It's basically an organizational report card. In this case, you also evaluate your MSSP and MA populations against each other for a more accurate comparison. It combines insights both from the landing page and the ACO scorecard that are really helpful for contract negotiations. Now with Salient, you're also able to get a look at what's going on across your organization, your practices, your providers, and your different populations, because I'm going to go ahead and change the way that I'm looking at the data. So let's go ahead and compare how our TINs are doing. You can see how they're doing in a graphical view as well as a tabular view. Now I can also create a provider profile. So let's say that I want to take a look at how a specific TIN is doing. I'm going to go ahead and pick on Addie McClure for the time being, and you'll see all of our metrics are updated to reflect specifically that practice's information. So you can also manage patients across all populations through annual wellness visits, TCMs or transitional care visits, and chronic care management, the CCM. I can navigate over to our quality overview dashboard to show you how we get quality measure information. These are instrumental for the success in value-based contracts since many arrangements are tied to quality outcomes, and this enables you to better manage patient care. We also have a post-acute care overview dashboard that helps you answer some why questions about the effectiveness of your transitional care visits that your organization is performing. As you can see, Salient platforms are really dynamic, and the patient level data is really at the tip of your fingertips for each provider that helps them really drive provider engagement as well as change. I'm going to go ahead and hand it back over to Mike so he can talk about how the Salient healthcare dashboards can be utilized to help that assessment.
Thank you, Maria. That was great. I can share with the audience that I have visited with physicians and presented dashboards that were far inferior to what Salient has. And the reaction from physicians when you show up in their office with dashboards that are difficult to read, difficult to digest, and don't really offer valuable data points creates a situation you really don't want to be in. I was really impressed with the Salient technology and tool and dashboards for several reasons: the user friendliness, the clarity, the accuracy, and the ability for physicians and physician leaders to digest the important information almost immediately. So thank you for sharing those, Maria. It's always great to see the dashboards and all the important metrics there. Sullivan Cotter provides a value-based care readiness or performance assessment for clients all over the country. One of the pieces of the assessment is compensation design or incentive alignment, as well as performance management. Our experience has taught us that a current state analysis or assessment is almost always the best first step that a health system or organization can take, whether they are entering the risk world as new entrants or moving towards a more aggressive risk-oriented ACO track, or potentially partnering with a commercial player in the risk world. These assessments can vary in length and cost depending on size of client, number of physicians, number of risk contracts, and other affiliations or arrangements that specific health systems or organizations may have. You will see on the left the value-based care focus areas. We bucketed those into 5 distinct areas, and the key readiness assessment deliverables on the right that you can read. I do want to share that Sullivan Cotter has great case studies that demonstrate the value and effectiveness of these readiness and performance assessments. I also want to talk a little bit about the organizational readiness roadmap for implementation deliverable at the bottom of the list. What this roadmap for implementation illustrates are key areas that health systems should be considering in the value-based care space almost immediately. Some of these areas are care team management and deployment in the outpatient space, physician education and engagement, post-acute strategy and utilization management, transitions of care, social determinants of health, and how to incorporate those into some of your strategic decisions. And lastly, patient and consumer education. Part of the assessment, Sullivan Cotter would provide recommendations and next steps for how to tackle each of these specific roadmap areas and help with implementation. Salient and Sullivan Cotter is looking for pilot opportunities, clients that may be interested in utilizing both the Salient and Sullivan Cotter services and advisory services. So if anyone in the audience today has interest or knows of a client that may have interest, please speak up or reach out to me or Maria directly. We would be happy to have a conversation about what a pilot might look like and how Sullivan Cotter and Salient might be able to help collaboratively with your value-based care strategy. In conclusion, we wanted to share a high-level example of what a larger scale value-based care transformation project might look like from a timing and milestone perspective. I understand that we have shared a lot of information. It will be shared with all of the audience members. You will be able to view this recording or share it with other colleagues or clients, and that's always a great thing. This example and the cadence here is important, but it also is important to remember that these steps all overlap and are constantly being monitored, developed, and measured. This particular client started with a very robust and detailed 4-month readiness performance assessment. As a result of this VBC assessment, the client began discussions around compensation design and value-based care incentive alignment. Performance monitoring and physician engagement was occurring almost throughout the entire process, and ultimately VBC implementation and program design takes over and really starts to take form. As you can see, there are many critical pieces to a successful value-based care model. Both Maria and I do believe that the intersection of compensation design and performance management is a very important one of these pieces, and it should be given significant attention when developing a successful value-based care model or program. Maria and I both really appreciate everyone attending today, and we hope this information was informative and insightful. Maria and I would love to take questions at this moment, so hopefully there are some good ones.
Okay. Well, thank you guys. Yeah, this was very informative. There was a lot here, and for those of you who are listening, you know, we will have the slides available for your review. But we did have some questions that came in that we want to get to in the allotted time here. So in no particular order, I'm just going to kind of fire away. The first one is, what are some of the best first steps in aligning payer contracts and provider contracts?
That's a great question. Was that designated for Mike or Maria?
It was not specified either way.
Okay, I'm going to let Maria take a stab at it, and then I have a few things I'd like to add.
Yeah, absolutely. So taking a look at a performance management system, it's really important that you have alignment and parity across all of your contracts and across all of the KPIs that I had just mentioned. So for example, looking at quality metrics, ensuring that all of your quality metrics are in alignment, because it's really difficult to track how you're doing on quality if the quality metrics are different across each one of your contracts. So for example, if you're reporting on quality on hemoglobin A1Cs, then you want to track that across all of your populations, not just a few of them.
Yeah, I would definitely agree, Maria. Understanding which measures and metrics some of the contracts are including or focusing on is certainly an important piece. It's also really important to make sure that the physicians are educated and engaged about some of these contract details, which thresholds and which measures and metrics they need to be aware of in their practice. I believe, and I have seen from my experience, that this starts with the primary care physicians and advanced practice providers. The level of engagement for these physicians and APPs is often critical. And I have seen that value-based care management teams in some organizations do not invest the proper time in transferring or transmitting that information from those contracts or the payers down to the physician level and the practice level so they can be more aware and ready to manage those metrics and measures. Great question.
Okay, great. Next question here is, how have the new Stark laws played a role in any of the incentives or designs of provider compensation?
Great. I am glad someone asked about Stark. I have one of my colleagues here with me, Ron Vance, and I'm going to let him answer that question.
Thanks, Mike. Great presentation by Maria. So for the audience that isn't familiar, there are federal regulations that have changed recently that affect physician contracting issues as well, and particularly how you pay physicians. So from the federal side, there was changes announced in Stark law that have opened up new value-based arrangement or VBAs that will effectively, under a certain set of scorecards, allow for physicians to receive what at least previously we weren't able to pass on as compensation. So that can include arrangements with risk and without risk. And the higher the level of risk it appears, the higher the level of compensation that can be passed on to the physicians. Without getting into all the technical requirements, this is a big change in the marketplace. There's a lot to be clarified from these recently approved regulations. But what they're going to do is they're going to put pressure on the health systems or the groups to be able to look at whether it's under the federal Medicare, Medicaid programs, or increasingly, as we see opportunities under the commercial payer programs, to look at what are those behaviors that will check the boxes and make sure that we've met the compliance. The biggest change is we had a lot more pressure about fair market value constraints on these payments for value-based care. We believe the new value-based arrangement exceptions are going to open up more opportunities. There's this whole other concept called commercial reasonableness that will still apply, which means it just has to make great business sense. And so there is still some clarification and some lingering needs to ensure that you meet commercial reasonableness. But it's an exciting time in that intersection for compensation and value-based care. And we think the Stark regulations and the anti-kickback regulations that just changed, they're going to open up new opportunities. More will have to come as we get clarity.
Great. Okay, moving along here. Can you elaborate around payer contract alignment and practice transformation to value-based care?
Yeah, so I can take that one.
Okay, great.
Each contract that you engage in is going to be slightly different, whether you have a Medicare, Medicaid, MA commercial contract, and all the populations obviously vary. The terms of those contracts are also going to vary. So, for example, you might have different quality metrics, as I stated earlier, different benchmarking methodologies, risk score calculations, etc. The data you're going to receive from the payers are also going to be different, and it'll arrive at different times throughout the year and throughout the month even. For contract negotiation perspective, it's going to be really helpful to align them as closely as possible, as we had said. And having the data in a single solution, as you have with Salient, is going to be really helpful. And you can also obviously leverage the Sullivan Cotter's expert team of consultants to help you identify the areas of opportunity for your organization, so you can really focus on executing those strategies and initiatives across the practices and your patient populations.
I'd like to add to that, Garrett, if I can, and Maria brings up a really good point. Although the contracts and arrangements and measures and metrics are different at times, and in most cases will be different, it is really important to have a strong foundation and a strong understanding of value-based care, population health management, where you are on the continuum, how engaged your physicians are, how engaged your physicians' staff are with this strategy and process, right? So I have seen examples where administration understands where they are, where they want to go from a risk perspective, how much risk they want to take on with payers and CMS, but physicians are left out in right field and don't understand there's a disconnect between administration and the physician network. This absolutely cannot happen. So physician engagement is a huge piece. Education and almost in some cases hand-holding during the transformation process is a critical step. Let's remember that physicians and advanced practice providers, they went to school to be clinicians and provide and deliver care. Reading and staying on top of all of the regulatory and compliance issues and changes is often difficult for them to stay informed about. So when you're undergoing one of these larger transformation types of projects or strategies, it's really important to make sure that your design, your program, and your foundation is really, really strong.
Okay, great answer, and good question. Okay, next one is directed at Mike. How important is physician engagement in this process, especially from an operational perspective?
Wow, someone read my mind there. I think I may have answered some of this already, but what we're really talking about from physician engagement perspective is physician behavior change. Physicians have worked in environments where productivity and volume and fee for service and number of patients seen per day has always been really important. And in most cases, physicians have been very successful in this model, both financially and from a care delivery standpoint. Consultants, thought leaders, health system leaders are now asking physicians to practice in a different way and change their practice styles and behaviors. This is something that most physicians that I have encountered in the last 5 or 10 years don't always accept easily or willingly. So the physician engagement area and education area, or hand-holding in some aspect, and I certainly don't mean that in a negative way at all, I mean it as a supportive and not additive piece, is a critical step in developing a successful value-based care model, right? So you almost have to treat the physician as if they don't know why they're undergoing this transformation or change, and then give them ultimately the toolkit and resources and accurate analytics and fundamental elements they need to be successful. If the physicians feel engaged and they feel like they have the resources and accurate data and, for example, a single solution or a single module for analytics like the Salient product, they will quickly engage, quickly adapt, and adopt this new type of practice style. I have seen this firsthand. I have been in the trenches with physicians at the primary care level in their practices as we ask them to see not 25 or 26 patients per day, but let's see 17 or 18 patients. Let's leverage the pharmacist that's now a part of your office and care team. Let's leverage the licensed social worker and the clinical therapist that are parts of your care team, so that you, the physician, can focus on the more chronically ill patient or the higher acuity patient, and hopefully control or contain costs and utilization in the future and provide ultimately better care for that patient. So as I'm rambling here, there are certainly lots of moving parts and lots of pieces and lots of important areas that you need to invest in, but physician engagement and education and moving them along the risk continuum in parallel with the administration is a huge piece. I would probably say physician engagement is at the top, if not number one, in terms of strategic initiatives for investment and resource from the administration level.
Wonderful. Next question is, do you also detect or look at the low value care procedures in the provider network?
Ron and Maria can chime in after. My answer is absolutely yes. Those are different aspects when it comes to utilization, which procedures, that question often takes us away from primary care at times, but the simple and overarching answer is yes. Physician activity and behavior and which procedures they are executing or involved in is certainly a piece of the puzzle.
And I'll chime in that with the Salient Performance Management Solution, you are able to look at the specific procedures, the diagnoses, and trend them over time, as well as look at the claim line details.
Yeah, this is Ron. I'll just chime in for the audience that it's a really good question, because part of this is not as linear as what one provider is alone going to do. So when we're talking about this intersection for value-based care and compensation, we want to make sure we have looked at all the activity and all the access for patient care and who's going to do delivery. This question really gets into the begging, like physician and APP optimization. Where can I allocate who's going to do delivery of care? Let physicians work to their top of license, let APPs work to their top of license, and make sure that we haven't created competing systems or either competing systems or barriers because of the comp design that would inhibit us from having a care team approach. So I think, back to Maria's comment and Mike's comment, you want to look at all the activity, and at the end of the day, it's that population that we're trying to manage, and we're trying to make sure that we've had supportive and complementary compensation arrangements that will at least reward, or if necessary, disincentivize behaviors that stop us from looking at the full continuum.
Very good. Next question. We have time for about two more, then we'll have to wrap it up, unfortunately. The next one is, do you make recommendations for disease state testing to improve HCC coding, like vascular?
Yes, we do. When I have worked with primary care providers, we have done significant amounts of education around certain chronic disease states and risk adjustment and HCC values, not only with primary care, but with specialists. There is a significant amount of training and education that comes along with risk adjustment and the whole hierarchical condition category, or HCC strategy or philosophy. I have been in physician practices where the physicians are very knowledgeable about HCC methodology, and I have been in practices and environments where the physicians have never even seen the acronym. So again, that falls back to the readiness assessment piece and finding out where they are, but recommended procedures and solutions and coding pieces for those disease states is certainly a piece of the puzzle.
And I'll chime in as well. So appropriate coding and making sure that you really take into account which codes that patient specifically has and accurately reflecting them is really key in value-based contracting. And what we do is, again, from the KPI perspective, take a look at what was coded last year. How has that score changed over time? And you can even look at it at a patient level to see if there are any codes that have been coded last year that were not coded this year. So of course, the example that we all like to use is the quadriplegic patient that probably did not grow a limb this year. So making sure that those codes carry over is something that you can do with the Salient solution.
Okay, yeah, great. And then the last question here is, how much of shared savings typically gets shared with the physicians?
Wow, that's a great question to end on, Garrett. Thanks for saving that for last. Great question. I have worked with clients in the past, and Sullivan Cotter has worked with clients in the past that have experienced positive shared savings situations, and I can say that it varies from client to client, from state to state, region to region, on how those clients share or invest or reinvest the shared savings from certain risk contracts. I have seen situations where those shared savings dollars are shared back with physicians and APPs, and some situations where those shared savings are reinvested in the entire program?
And Mike, as Ron, I'll chime in for the audience as well. You know, there is some OIG, Office of Inspector General, compliance restrictions that appear to suggest up to 50%. There's a string of advisory opinions that would be limiting about sharing more than a certain height. With the new Stark regs being passed, that's an open question. But as to Mike's point, we've seen significant Medicare shared savings programs, other ACO savings passed on. And then the question becomes by initiative. So it's not always a single answer to, you know, up to 50% is probably pretty typical, down to as low as 20, 25%. Just depends back to Mike's comment about what gets reinvested. The point here is there can be sub-allocations under those savings depending on where the risk payment or where the shared savings came in. And so that can go to different programmatic approaches. And so it's not a one size fits all depending on what the specific initiative was.
Okay, great. Well, unfortunately, that is all the time we have. We've kind of run up on time. So thank you all so much. Thank you, Maria and Mike and Ron, for jumping in at the end there with some of the questions. If we were not able to get to your question today, please know that we will make sure to reach out afterwards and to answer those questions directly. And if you have one that comes up last minute here, go ahead and submit it now. You know, we can still take those. As we conclude, I wanted to encourage you all to visit the Salient Healthcare booth at acoexhibithall.com. It's a virtual exhibit hall. They have an interactive booth that's really cool. You can get to know their products better and interact with their team here and learn a little bit more about them. And also, this is at acoexhibithall.com is where the recording will be housed. So if you, for whatever reason, if you don't receive the email later on, that I'm going to be sending out afterwards, in the library archive, we will have the recording that is stored there, along with a lot of other webinar recordings that we've done. So please check it out. And as we close out here, if you have any specific questions for either of our speakers or for Ron or the Salient team, their contact information is here on the slide. Feel free to take a note of that and to contact them directly and reach out, and they'd be happy to follow up for further discussion, or you can reach out to me directly and I'd be happy to put you in touch as well. So thank you all so much for attending. I hope you found today's presentation helpful and informative. I certainly did. And stay safe. Have a great rest of your day, and we'll talk to you next time. Bye now.